I'm going to talk about implicit bias and race. In 2003, the Institute of Medicine published this landmark report really called Unequal Treatment Confronting Racial and Ethnic Disparities in Healthcare to really highlight the increasing data that there are racial disparities that are very significant to U.S. healthcare. It's essentially been demonstrated that racial disparities affect all kinds of surgical specialties, especially cardiothoracic surgery. For example, Black patients have been demonstrated to undergo coronary revascularization procedures, especially CABG, significantly less than white patients who have the same clinical disease, and with, related to that, worse survival outcomes. Also, the treatment for esophageal cancer and outcomes from the treatment, as well as the rates of curative lung resection for early stage lung cancers are also worse for Black patients as compared to white patients. In this report, they don't just talk about all the evidence that establishes the racial disparities. They talk about how important it is to figure out why these disparities exist in order to address the problem. They point out that a lot of the studies, even if they control for patient and clinical factors, a lot of them, most of the time the disparities persist. And so they suggested that most likely something is going on, at least in part, at the patient-physician level. And they encourage that more research be performed to see what is the potential relationship between implicit racial bias and racial disparities in healthcare. I picked this article because it addresses a very well-documented racial disparity that Black patients are prescribed pain medications less than white patients. But I also thought it was just a really interesting study. So in this experiment, they created two study groups. One that was white non-medical people, 92 people, who were asked to look at this list of statements about biological differences between Black people and white people and make an assessment of how true they thought the statements were. The majority of, almost all of these statements are totally untrue, and some of them are like really kind of crazy, like Black people's nerve endings are less sensitive than white people's. One of those, Black people are better at detecting movement than white people. They then asked those patients to then review 15 clinical scenarios where patients had pain, and they would show them Black patients and white patients and ask them to rate their pain. They then created a second study group of white medical students and residents, and then asked them to look at the same list of biological differences, and then also asked them to look at some mock medical scenarios and make an assessment of the patient's pain, in addition to making recommendations about how the pain should be managed. And the patients were alternating Black and white patients. What they found was that a surprisingly large number of both medical people, trainees, and non-medical people actually believed these biological differences existed. This study came out in 2016. They also found that for the people who were high scoring for having false beliefs, that clearly correlated with scoring Black patients' pain as being a lot lower compared to white patients for the same scenarios. They also showed that in the medical group, not only did they show racial bias on the perception of pain for the patients who scored high on the false belief scale, but that also led to racial bias in terms of the pain management that they recommended. The most common, the most common tool that's actually used for these studies to find an association with implicit bias and racial disparities is actually the IAT, the Implicit Association Test, which Jessica talked about earlier. Now with the growing body of literature, it's essentially demonstrated that across the board, healthcare providers show pro-white racial bias, implicit bias, despite the level of training and across all disciplines. What it doesn't show totally clearly is what exactly the correlation is with the presence of implicit bias and then actual healthcare outcomes. There are very mixed results actually from the majority of studies, and things that people have mentioned as possible explanations for that, just general things related to the quality of the research, like small sample size, non-responder bias. People have also brought up that the IAT is used in conjunction frequently with clinical vignettes that may or may not really represent what's happening in real life. And also the possibility that there might be some clinical scenarios, probably ones that are more algorithm-based, that are less vulnerable to the effects of a healthcare provider's implicit bias. The IAT has actually also looked at whether or not implicit racial bias could be affecting medical school admissions. In this study, 140 members of an admissions committee at the Ohio State University Medical College were asked to take measures of explicit and implicit bias before interviewing medical school applicants that year. What they found is that across the board, nobody had explicit bias. What they found that across the board, male, female, faculty, medical student, all of them had pro-white implicit bias that was significant. In fact, they found that especially the males in the faculty groups were the highest scoring for implicit bias. So there are still some significant gaps. A lot of the research has been done in black versus white populations, but a lot of research is still needed to look at racial disparities in healthcare for other minorities and ethnicities. There's also, interestingly, very little data about how implicit bias might affect provider and provider interactions, and also how it might affect a diverse healthcare team and how that then translates into patient outcomes. The other thing is that implicit bias isn't necessarily the only thing that can affect the racial dynamic that then perpetuates racial disparities. So for example, racial anxiety, that just means essentially having anxiety about interacting with someone of a different race. And so an example of that would be someone has anxiety about interacting with someone because they think that they're going to be the target of discrimination. It could also be you have anxiety about interacting with someone because you think that they're going to perceive you as or treat you as being racist. That sort of leads into one of these other concepts of stereotype threat, where it's essentially a self-confirming belief that you as a member of a certain group will be evaluated by a negative stereotype that affects that group. So the most commonly used example is how girls perform in terms of the science, technology, engineering, and math fields. One other concept is microaggressions. An example of this, I want to just mention something that happened in clinic the other week. I go to a clinic at another hospital maybe 1 or 2 times a month, but I've been there for 5 years. And so I was in the workroom with the medical students and the residents, and one of the clinic assistants came in and she was like, "Oh, Dr. Yang, your patients are roomed." And I was like, that happens all the time. There's an Asian surgeon at that hospital named Dr. Yang. So I was like, I'm not Dr. Yang, but okay, I'll see the patients. And the guy standing next to her, another clinic assistant who has also been there, like the five years I've been there, was like, that is not Dr. Yang, that is Dr. Lee. And I was like, good one, that is pretty funny. Except the whole rest of the day, they literally called me Dr. Lee, and it finally dawned on me, they really thought I was Dr. Lee. And it was so upsetting. I was like, you guys, Dr. Lee is a man. I was like, I cannot believe this. Are you insane? And I'm not proud that I got upset, but maybe it's racial anxiety. I don't know. I was just like, could not believe it. And then I happened to come across this video, which I didn't think we would have enough time to show here, but you should definitely Google, if you Google microaggressions and mosquito bites. Essentially what they're saying is that if you consider microaggressions as mosquito bites, when you get them once in a while, they're just really annoying. But for some people get a lot more mosquito bites than other people. So if you're getting them all the time, multiple mosquito bites, or you're attacked by a swarm of mosquito bites, even though each individual one doesn't kill you, it's a very significant deal that it can chip away at your individuality and at your self-worth. And so that microaggressions are very serious as well. So in conclusion, I want to summarize that implicit racial bias in terms of racial disparity in healthcare is obviously very important. I mean, essentially based on this data, it has the potential to kill people or ruin people's careers. And in terms of microaggressions, the ability to really take away your individuality and reduce your self-worth. And that's why we should really pay attention now to Dr. Higgins' talk on how to fix implicit bias.